Hi, thank you. It's my pleasure to be here today. And I want to give a huge thank you to Pain BC for hosting us. Pain BC has been nothing but supportive ever since we launched the National Pain Advocacy Center, and we really so appreciate everything they do. So today I'm going to talk to you a little bit about the National Pain Advocacy Center. It's a relatively new 501c3 nonprofit organization. It's in the US and organized in the state of Colorado, although we do have a couple of Canadians in our group. Dr. Hans Clark, who is the head of pain services at Toronto General Hospital System, is one of our advisors, as is Dr. Samina Ali, who is an emergency room doctor, which is an important area of interface for people with pain in the healthcare system, as well as an expert in treating pain in children. And Chris Freeman, who is one of our people with lived experiences and advocates at NPAC. So our mission, as you see, is on the slide, advancing the health and human rights of people with pain. We started really working together in 2019, filed our paperwork at the end of 2019, and didn't hear from the IRS with our nonprofit status until well into 2020. Amidst a global pandemic, everything was a bit delayed. So while we continued advocacy, we decided to really pivot into having a rich online presence, a really informative website, and social media campaign that we launched early this year. So we are a relatively new organization. Next slide, please. So our vision is pretty straightforward as well. We envision a world in which pain is treated equitably and effectively, so all people living with pain can lead full and productive lives. We are very interested in the inclusion of people with pain in social and economic life. So a lot of groups probably have similar missions. So why did we think it was important to start a whole new organization? I want to tell you 5 things that are sort of distinguishing features of NPAC, so you can get a sense of why we formed and what we're about. Next slide, please. First of all, unlike the way in which Pain BC rather is organized right now, we approach pain from a federal or national point of view. Although we work in states on occasion, our focus is really on federal actions. And the reason we do that is because most of the policies that shape pain care in the US, from payment systems to access to care, happen at the federal level, in federal administrative agencies, primarily like the Centers for Disease Control and Prevention, the Food and Drug Administration, the Center for Medicaid and Medicare Services, which really determines payment structures, and really the National Institutes of Health, which does our research. So a number of federal agencies, and then of course we also work with federal legislators because appropriations also matters. Next slide, please. Number 2, and this is a big one that makes us unique. As an organization, we have pledged not to accept funding from pharmaceutical companies or any industry interests that might create an actual or perceived conflict of interest. This is really important to have credibility in the pain conversation because of the way in which commercial interests, opioids, and pain have intersected in the United States and to some degree certainly in Canada over the last couple of decades. It's very difficult to have credibility in the conversation while having any kind of relationship with these commercial interests. So we began with a grant from an organization called Open Society Foundations. And we have other sort of fairly strict ethical policies as well in terms of making sure that our advisors have submitted disclosures and making sure that we don't take any money that has any influence on our policies or positions. And the interesting thing about this is that this matters not just in relation to advocating for appropriate opioid prescribing or for protecting the rights of people who actually do require opioids to manage pain. it matters for the conversation about pain more generally too, because there is a bit of an attitude amongst policymakers of fool me once, shame on you, fool me twice, shame on me. The idea that, we believed you before that pain was important and look where it got us. And so pain has kind of been stigmatized with guilt by association. And so we're facing a pretty high upward climb there. And so we thought it was really important to maintain a pretty strict ethical policy. Next slide, please. So our goal is to transform how pain is understood and treated. And again, it's interesting. I was looking at the Pain BC website just shortly before this webinar launched, and I see that there's a very similar phrasing on their website. So we all know this is what's needed. We all know that pain is misunderstood, it's oversimplified, it's highly stigmatized, and it's really poorly treated relative to its prevalence and consequences throughout the healthcare system and society. What makes us a little different is how we approach achieving that goal. Next slide, please. So we really focus exclusively on policy and advocacy. We want to work to shift perceptions and policies for a systems level transformation or change. So we're not doing any kind of casework for individual patients. We don't have a hotline like Pain DC does. We really just focus on education, advocacy, and policy change. Why are education and advocacy important? Well, for one, how we think about pain really informs our willingness to invest in its treatment. So raising awareness about the real consequences of living with pain is important to getting policymakers and others in the country to care about pain. And then on the other hand, policies really often shape who gets access to care. So policies matter. In our work, we advocate for policies that are grounded in science or evidence, but also in equity and compassion. And we work against policies that endanger the health and rights of people with pain. Next slide, please. So another thing that makes us really somewhat unique is how we're formulated. The idea is to have a big tent, to have everyone who's necessary for good pain policy in the same room, really thinking this through. We're aware that the subject has not always been treated with nuance, and so we really want everyone involved. Number one, NPAC was started by and for people with lived experience of pain. Myself, most of our board are people with pain. We also have an extensive community leadership council, which I'll tell you a little bit more about in a minute, that is race, gender, LGBTQIA, and regionally diverse, but also represent individuals living with a variety of conditions causing pain and often causing high impact pain. They're an extraordinary group of people who are all very capable advocates and professionals in their own rights, but are dealing with serious pain. NPAC also includes scientists and clinicians, because you don't just need people with lived experience. We also need the scientists who can help us translate evidence and evidence-based sort of treatments into policy action. And you need clinicians, that's another kind of lived experience, who know what it's like to work in the trenches and treat people living with pain. But you don't just need people with lived experience and scientists and clinicians. You also need good policy people, because what we're trying to do is create better policy. So you need people who are experts in public policy, in health policy, in drug policy, in civil rights, working jointly. And that's really what we've tried to do with NPAC. We really believe in a combination of evidence and experience-based advocacy. So advocacy that incorporates a variety of disciplines and perspectives. And the perspectives part is important too. We don't want to fall into groupthink. We don't all have the same points of view. And though our board and I determine what policy positions we ultimately take, we really want people to be free with their ideas, their understanding, their background choices, and help inform good policy. And finally, we also take a non-binary approach to pain and addiction. Pain and addiction are different conditions with different needs, but they're both highly stigmatized, misunderstood, and poorly treated. They have intersected in this crisis. There has been, I think, often between the pain and addiction communities, a sort of infighting approach where it's sort of us or them, or a zero-sum game that, prescribing opioids is a zero-sum game. We either treat pain or we prevent addiction. And, the truth is actually much more complex than that. Bad drug policy harms all of us equally, I would say. And there are people with pain who have addiction. And there are people with addiction who develop pain. So we also have among our scientists and clinicians experts in addiction, as well as I said, in our health policy expertise. We have people who work in drug policy, and we have people with lived experience of addiction, of opioid use disorder, who are in recovery in our group as well. Next slide, please. So the final thing that really makes us somewhat unique is that we look at pain treatment through a rights and equity lens. We believe that pain management is a right. Access to care is a right that's protected as a civil rights in the United States under the Americans with Disabilities Act. But it is a broader global human rights issue because pain can affect anyone, regardless of race or gender or age. And it really does implicate the most basic aspects of human life, one's ability to function and to work and to enjoy social and family life. So we think it is a right that's important to protect for everyone living with pain. Next slide, please. But it's also the case that not everyone's pain is treated equally. And one reason that this happens is that pain's invisible and its experience is subjective. So how others perceive it, whether it's a provider who's treating it or an employer who's deciding whether you get an accommodation in the workplace, depends a lot on how the person who is suffering with pain describes their pain and whether the person who's listening believes them, whether they're taken as a credible witness to their own experience. So what this means is that all of the dynamics in a society, including its structural biases, can come into play in pain treatment. There's a philosopher named Miranda Fricker who calls this idea testimonial injustice, which is the idea that you are disbelieved based on your identity or the group that you associate with or are associated with by the person who's listening. Next slide, please. So, for example, we talk about pain as a racial equity issue. Some medical conditions disproportionately affect people of color, people of certain races, but it is more poignantly the case that, particularly in the United States, Black and Latinx people are more likely to have their pain rated as being less severe by providers due to false ideas about biological differences among the races. So they're not as likely to have their pain taken seriously or believed on the one side. And then on the other side, because of the way in which in the United States, we have waged a drug war disproportionately against communities of color, if they are a patient who would benefit from opioids, they're more often perceived as being drug seeking and are given less medication as a result of their race. Next slide, please. So pain is also a women's health issue. We know that chronic pain disproportionately affects people who identify as women. And some studies show that up to 70% of people with chronic pain are women. Yet, in spite of this prevalence, women are more likely to have their pain also dismissed or disbelieved. Next slide, please. So pain is also, I touched on this a few minutes ago, a disability issue. Almost 20 million Americans have pain that prevents them from engaging in basic life activities in the United States or working. And that is sort of the classic definition of disability under the Americans with Disabilities Act. Pain is also the largest cause of long-term disability, both globally and in the United States. And people with disabilities face heightened barriers to care. Next slide, please. Pain also matters across the continuum. Children's pain is very often underestimated and undertreated, even though younger people experience pain at pretty much similar percentages to adults. And it really matters because how we treat children's pain will shape their development and their lifelong relationship with healthcare. Next slide, please. Pain is also an issue that affects older persons who may also have heightened barriers to care. In particular, long-term pain is one of the most common, and capacitating conditions in older adults. Next slide, please. Pain also disparately affects people in the military or veterans who may have greater pain or more severe pain. Next slide, please. And pain is a health equity issue for a lot of groups. Many groups may experience heightened pain. There are some studies, for example, showing that transgender people may have more severe pain. And on the other hand, access to care is burdened for a lot of groups, such as people who are living in poverty, people who are living, at least in the United States, in rural areas, face greater barriers to care. So that is why we look at this as a human rights issue, but also an equity issue. Next slide, please. So those were the 5 things that made us sort of distinguishing or unique as an organization. I'm going to back up for a moment now and tell you a little bit about my personal story and what inspired me to get into health advocacy, as well as a little bit more about our origins as an organization. So as mentioned in the introduction, my professional background is as a civil rights attorney. I worked most of my career in the United States Department of Justice's Civil Rights Division, and I did enforce the Americans with Disabilities Act. And then a few years into my career, however, ironically, I became a person with a disability myself. So I was sitting at my desk working one day when my back started to burn really badly. It felt a little like acid was eating my spine. And pretty quickly, my muscles started to clamp and my whole body seized up on me and I fell on the floor from my chair. And after that, I really was largely unable to sit or stand and severely limited in walking for the next 15 years, and then on and off for the better part of 20 years. So I was pretty severely limited by my pain. I couldn't sit, so I couldn't even use a wheelchair, which made me a fairly unusual person with a disability, even working in a disability rights operation. And it took me a while, as it does for many people in chronic pain, to make my way through the healthcare system and find a diagnosis. It ended up being tied to a surgical injury I'd had to nerve plexus, major nerve plexus leading into my spinal cord. But over about 3-year period, I had a lot of positive tests, of course, because I did have, I couldn't walk. And so my nerve conduction studies were abnormal and I had a lot of inflammation. And so I was also diagnosed with ankylosing spondylitis. They thought maybe I had MS. I accrued a lot of different diagnoses before they really sort of settled on this one. But I have to say that was maybe 3 years. And for many people in NPAC, it's taken an awful lot longer. There are several people on our community leadership council, people with lived experience, who've waited a quarter century for answers to their high impact daily pain. So I tried a lot of different kinds of treatment. I was lucky enough to be treated in a multidisciplinary pain clinic back in the day when those existed in greater number in the United States. I had good health insurance because I worked for the US government. But pretty much everything they tried just didn't really manage my pain very effectively. And that included, sort of multimodal care, lots of blocks. I even had a surgery where they went back in and tried to redress the surgical injury, but it just wasn't successful. And after that, my doctors said, really, you need to try managing your pain with opioids. Up to that point, I had really steadfastly avoided them, less because I was afraid of addiction and more because I felt like the one thing I still had going for me was my mind, and I was afraid that they would make me foggy and create more difficulty in my ability to work. But I did try them, and they actually helped me work and function, and improved my quality of life. And so I took opioids for several years. And then flash forward many years later, surgical techniques improved. They were able to get me back to a point where I could recover my mobility, which was pretty exciting. And I moved to Colorado, actually, when that happened, to really focus on rehabilitation, and was already going down on my medication when I went into the doctor one day, and my doctor informed me that she wasn't going to prescribe to anyone anymore in her practice, effective immediately. And she didn't think I'd find anyone else in the area who was willing to prescribe to me either. And what had happened is that a local doctor had who was pretty well respected, had come under the auspices of the Drug Enforcement Agency in the United States. And that really sent shockwaves through the local prescribing community. And she was right. I wasn't able to find anyone who could give me a taper plan in the local area. But fortunately for me, I was already getting better. I was already going down on my medication. So it was really just getting safely tapered off that I needed. And I was able to connect with my prior treatment team in Washington, D.C. And get off of the medication. And I did fine. But it did show me what was coming in the current environment. That was in 2015. So it was before the Centers for Disease Control and Prevention issued its 2016 guideline for prescribing opioids for chronic pain. But after that happened, and sort of by 2017, I had some other sort of vicissitudes in my health, but I decided to start advocating in this area because I began to hear through the disability community about what happened to me happening to a lot of people. So I got up and gave a TEDx talk. That's what this photograph is from. Started writing op-eds and really engaging in the conversation around appropriate pain treatment, and in particular, the harms that were coming to people who had been prescribed opioids to manage pain, people who the healthcare system put on opioids, who were sort of suddenly being cut off or abandoned in dangerous ways. The other thing that informed my thinking about this issue is my professional experience. So when I started as a civil rights lawyer, it was during an HIV and AIDS crisis in the United States. And one of my really big cases involved whether someone with asymptomatic HIV and AIDS, so where there was no risk of transmission to a provider, had the right to routine healthcare. And we had to win, in this case, it was dental care. We had to win that right all the way to the US Supreme Court. It was that controversial. So I saw in those days that in these public health crises, we often end up othering and stigmatizing the very people we are trying to help. And that, ironically, can lead to discrimination in the thing they need most, which is access to healthcare. And that's what's happening. I saw happening to people living with pain today. Next slide, please. So as I began working on this issue and advocating on my own, I came across other people who were also seeing these problems and advocating. And so I worked with a number of them on a few different things, and all of them are part of NPAC today. So I'm telling you this just to sort of give you a sense of the iterative way in which we formed and began. So one effort, Beth Darnell, who is one of our science and policy advisors, with some others, put together an international stakeholder letter on the dangers of forced tapering. And that was in 2018. It got a lot of media coverage on 4 continents, I believe. And one of the reasons it did is because she was very skillful in getting people to sign on who had different ideas about the philosophy on opioid prescribing or the appropriateness of prescribing for people with pain, but who understood that once you had people on opioids, rapidly taking them off was not a good idea. Another initiative was a letter campaign that was started by 4 clinicians, 2 of whom are our advisors, Sally Sattel and Stefan Cortez and others, put together a letter that was signed by 3 former drug czars in the United States and hundreds of providers that really was raising this issue to the next level and saying to the Centers for Disease Control and Prevention, hey, what you put out as guidance for primary care clinicians is being lifted and applied in very strict ways throughout the policy environment. And that's harming people. That's harming people who have pain. And so that letter got a fair amount of attention. It was written up in the New York Times. Around the same time, or shortly before that, actually, Human Rights Watch had written a report at the end of 2018, I think it was, on what was happening to people with pain in the United States. Laura Mills, who was with Human Rights Watch, wrote that report, and she is part of NPAC. She's on our board as well. And along with Laura and Stefan Cortez, I went to meet with the U.S. Centers for Disease Control and Prevention, and we urged them to issue a public-facing correction, which they did. So obviously, as with all policy changes, this was an effort that a lot of people were involved in. I'm mentioning it just to say that this was another way in which some of us came together to fight what was happening to people with pain. And finally, one other thing that happened was there was a proposal in Oregon. The idea may well have been well-intentioned. It was to expand coverage to a range of complementary techniques for treating pain, but the effect of it was to deny people who were currently on opioids their medication. So it would have effectively forcibly tapered about 100,000 people with no safety protocols at all. And Beth Darnell also worked on that, as did Sean Mackey, who was willing to host a letter that was signed by a whole lot of treatment professionals, and Andrea Anderson, and all of them are also involved with NPAC. Next slide, please. So what we started to see in those early years is coming to fruition, or becoming recognized anyway, at least in studies now. So we're seeing, with respect to patient care, studies suggesting that up to 50% of primary care clinics in the United States will not treat a prospective patient who uses opioids to manage pain. And a different study that was done by the Center for Addiction and Quest Diagnostics suggested that 81% are reluctant to. So these are pretty big numbers. Next slide, please. And this sort of fear about opioids is affecting people not just with pain, but also people with opioid use disorder. The Department of Justice had a couple of settlement agreements against treating providers who refused to take on someone because they took buprenorphine for an opioid use disorder. Next slide, please. Luckily, there has been increasing recognition that this is a problem and that people really do need access to care, that it's not a good end of public policy to see people dropped from the healthcare system. This is a letter that was issued now 2 months ago, I guess, in the state of California from the California Department of Public Health, recognizing that a common problem, what it describes as a common problem of many patients who use opioids long-term, find themselves suddenly stranded and without a doctor. Next slide, please. This is just also showing that there have now been a number of observational studies, but studies suggesting what we had seen coming, which is that taking someone off of opioids who's been on them for a long time, or even just tapering them down, is a more complicated proposition than policymakers first believed it would be. That discontinuation often happens abruptly with negative health consequences. That just destabilizing someone's dose can actually put them at an increased risk of death not a decreased risk of death, in addition to destabilizing their health, mental health, and lives, and that tapering is associated with dissolution of healthcare relationships. Next slide, please. So our work really emerged out of this concern, that the concern about what was happening to people who were prescribed opioids for pain. It's hard to know exactly how many there are because prescribing has dropped so much recently in the US, but studies suggest between 8 and 13 million people may take these medications. And so we were concerned about this because of its urgency, because it was an under-recognized and urgent harm. And we still do work on this issue. For example, in the last couple of months, we were invited to be speakers, panelists at a Food and Drug Administration conference on prescriber training. We met with the Department of Justice on algorithmic and AI discrimination that's happening, the flagging of patients through PDMP data, and the implications for their healthcare. Earlier, a couple of us served as appointed members to the Centers for Disease Control and Prevention's opioid work group, which oversaw or was sort of a reader for the CDC's updated guidelines, which will be issued early next year. We also worked to stop a bad federal law that was going to sort of misapply the CDC guideline across the country in ways that exist already in some of the states, but this would have made it a national policy, stopped. So we're still working in that area, but we're also quite aware that opioids neither are nor were the solution for everyone with chronic pain, and they're not solution for nobody either. The problem has been in this sort of overly simplistic application of a single modality to everyone, and then the decision to say, well, no, if you have any kind of chronic non-cancer pain, which is usually the term that's used, opioids are always inappropriate for you. Our interests, though, are much broader. We're aware that one of the reasons for this sort of simple or simplistic mistakes of the past is that we really don't have an infrastructure for treating pain equitably or effectively. We know, no one in this group will be surprised, that pain is rarely addressed in medical education adequately, even though it's very common. And one of the main reasons people seek healthcare, that research dollars for pain are far out of sync with pain's prevalence, and that there are barriers sort of up and down the chain in terms of understanding and treatment of pain. So it's complicated, it's difficult to change these big structures, but it needs to happen if we're really going to transform how pain is understood and treated. Next slide, please. So we are working on a positive pain agenda too, rather than just playing whack-a-mole against bad policies. We are working on how to create these systems level changes. One of the simple things that we do pretty routinely is respond to formal requests for public comment from federal agencies. We have one due to and also for professional agencies. The American Psychological Association has an open comment that's due on Friday this week. They are working on a guideline for, appropriate treatment for people with chronic musculoskeletal pain. We recently submitted comments to the National Institutes of Health's Office on Women's Health Research, which was asking about chronic relapsing conditions affecting women. And pain is probably the number one, and yet, pain is everywhere and nowhere. It is never mentioned in the chronic relapsing conditions affecting women. So we put together a comment about that really looked at the research over the last 20 years on pain and gender. We responded to a recent call for comment from CMS, the Center for Medicare and Medicaid Services. They are, for the first time, considering expanding coverage of chronic pain treatment, including medication management. And so that was a really important thing to respond to. We've responded to calls for comments on coverage of integrative and complementary care, because a lot of modalities for treating pain aren't paid for in the United States. In addition to responding to these requests for public comment, we also regularly meet with federal agencies and legislators. And we're also working on setting sort of our affirmative policy agenda. So one of the things we've done is to survey all the existing reports and proposals that are out there, including the Canadian Task Force report, which was very informative and useful, but the National Pain Strategy in the United States, the federal research policies, the recent report that was issued by an interagency task force headed by the Department of Health and Human Services, sort of looking through and deciding, what is the best way to go about changing these structures? Do we ask for sort of high-level policy changes that will have downstream effects, but maybe take a lot of time? Do we ask for very granular things that may take immediate effect? What exactly do we ask for? So we've gone through a lot of those reports and have actually come up with priorities. And now we're in the process, because consensus is really important for our organization, of having everyone rank those priorities, and not just what's your top priority, what's your bottom priority, but how do each of these rank relative to each other, so that we can get qualitative senses, a sort of chart for everyone about where they fall, as well as for our different groups within the organization and the organization itself, that will then facilitate exactly how we go about advocating for certain things. And secondly, in the process of doing that, I mentioned that health equity is a big part of what we do. In the process of looking through some of those reports, we found that some of them treated sort of pain equity in dated ways. And also because a lot of us come from the perspective of civil and human rights, or have worked on trying to mitigate implicit biases and done training about this, we felt like it needed a more sophisticated lens. In particular, there wasn't enough of an attempt to look at this through an intersectional lens, because people don't just fall into, male or female, or Black or white, or disabled or non-disabled. A lot of people have multiple coexisting identities, and the failure to look at that through an intersectional lens, we noticed, had a lot of implications, but one of them was that there were groups being left out. So for example, we know that pain disparately affects older people, and we know that there are real race implications for treating pain, but there's very little research, for example, on pain in aging Black men, at least in the United States. So we are working on that right now. We're working on what it really means to have accessible, or rather equitable, access to care across the spectrum in an intersectional way. And then once we have that sort of developed, looking at where the gaps are, and then bringing it back out to, again, approaching it through a broader lens. And that is something that I think we're going to spend a lot of the next year working on, keeping more experts, probably issuing some white papers about. Next slide. So just very briefly, I want to tell you a little bit about how we're actually constituted. See how we're doing on time. I guess we're okay. So this is our Science and Policy Council. Sort of looks like a yearbook photo when I look at it in a slide like this, but it is comprised, as I said, of scientists and clinicians and sort of health policy and rights experts. So for example, and a lot of the areas of expertise line up to our priorities. So for example, we have Hans Clark, who I mentioned before, and Dr. Sean Mackey, who are pain management experts, and who have also been involved in the national conversations in the United States and Canada, and in policymaking. Sean Mackey, for example, was involved with the Institute of Medicine's report on pain and the National Pain Strategy. So they are sort of our pain management gurus. And then we have a lot of people whose expertise correlates with some of the areas that we think are really important. So, for example, Dr. Tamara Baker is an expert on racial disparities and inequities in pain care, as well as in treating pain in older persons. Sabina Ali, as I mentioned, is an expert on treating pain in children. Monica Malampalli is an expert on sex and gender-based discrimination in pain care. Daniel Goldberg, who is a professor, a law professor and ethicist, is an expert on pain stigma in general and the effect it has, downstream effects it has on discrimination against people with pain. We have experts again in addiction care. Sally Sattel and Stefan Cortez are both experts in addiction, and both Stefan Cortez and Jen Oliva have expertise in also treating pain or care of service members and veterans. Stefan treats veterans and sorry, just looking at a note in the chat. And Jen is herself a veteran and a professor of public policy and public health policy. So Shilpa is an expert in patient-centered research, as is Beth Darnell, and Beth is also an expert in the psychological management of pain, CBT, and other interventions that can help people live better lives. Dr. Robert Shapiro is an expert in treating pain, headache pain, which is a large, often under-recognized, invisible cause of pain, and has done a lot of work with policymakers as well in the US. Lindsay Barron is the head of policy for the largest disability group in the United States. And then we have people like Ethan Nadelman, who until 2017 ran an organization in the US called the Drug Policy Alliance, which he had run since the 70s. It's the largest organization in the United States dealing with drug policy and the war on drugs. And Leo Beletsky and Jen Oliva are public health policy experts and law professors as well. So it's a real mix of science and policy, name of the council. Next slide, please. So what this council does is it does advise us on our policy development and positions. It also vets and helps us draft responses to requests for public comment that I mentioned recently. Individuals will advise us on issues as they arise in their areas of specific expertise. That happens pretty frequently. Members of the council serve on panels and respond to press inquiries, which also happens relatively frequently. And again, the group really initially sort of formulates evidence-based pain policy that are then vetted through the entire organization. Next slide, please. Another part of what we do is connecting real patients with policy advocacy. Next slide, please. So this is our Community Leadership Council. As I mentioned, it's quite diverse. I urge you, I won't go through every individual here since I want to leave plenty of time for questions, but they are a group of people who are all very accomplished advocates and professionals in their own right, but also struggle with and live with significant pain, and in most cases, high impact pain. They are diverse in pretty much every respect, and represent really a mosaic of the different conditions that cause pain. One of the things that I have found frustrating in the discussions about chronic pain in sort of the mainstream environment is that there's a fairly monolithic way of looking at chronic pain, and most of it is considering, sort of garden variety chronic low back pain. But, these are people who have cancer or post-cancer pain, people who have sickle cell disease, people with ankylosing spondylitis or rheumatoid arthritis, people with dystonia or MS, And so it's a broad spectrum, chronic pain. It's a big envelope. It's an umbrella category of conditions that vary so greatly, whether, neuropathic pain is hard to compare to inflammatory pain. And it's important for policymakers to see the complexity and the real mosaic of people represented, not only as individuals, but also their conditions in the chronic pain conversation. Next slide, please. So one of the things that we've been working on with this group is an effort we call Real Pain Stories. When we set up our website, I interviewed a number of people on the community council and wrote up their stories. And then just in September, we did a Twitter campaign that used the hashtags Real Pain Stories and Real Pain Story, where people really activated their life experience, told their stories in lots of different ways. One of the nice things about having such a capable group of people in the organization is that we have one person, for example, who's a creative writing professor and has written a book about pain and could sort of help people figure out how to fashion and shape their stories. And then we have other advocates who are really stellar on social media and talked about, how really to effectively use social media to tell your story. And people used we gave people different prompts. Some told 3 moments from their life, a beginning, middle, and end. Some used a photograph and described how it made them feel. But it was a pretty, I think, effective campaign to begin to talk about the real life experiences of people with pain. And we're in the process now of mocking up video interviews and stories. I'd hope to get funding for a full-fledged sort of documentary campaign that really harnesses the stories of these people, because they're quite compelling stories, and it's really important. One of the things that happens, raising pain awareness is so incredibly important, but one of the things that happens often with top-down awareness campaigns is they really are not grounded in lived experience, and that can lead to, oversimplification and stereotyping as a result. Next slide, please. So one of the things we're really working with this group to come up with, effective practices for health advocacy. So working on how to advocate. As I said, many of these people are super skilled, and we're working on this collectively. And I've learned a lot from a lot of the people in this group. How to tell your story. We came up with decision trees, because it's really important when you're sharing something both intimate and medical to be conscious about what details you share and what you don't, from sort of an informed consent point of view, but also just from a level of comfort. And we sort of went through role playing about how people would feel if someone responded to something they shared, particularly a really intimate detail in a particular way. We also talked about having sort of a personal social media policy and advocacy policy about how you deal with comments, because we all know that social media can be a wonderful way to get a wonderful democratic with a small d way to get experience out there, but it can also be a really difficult environment, and sometimes a triggering one. And so we talked about how to come up with sort of your own policy about what you'll share and how you'll respond and when you'll respond. And we've also worked with people about how to work with journalists, worked with people about how to work with policymakers. And the idea is that, we're working this out within our group, but once we have a pretty good set of tools, we will generate some advocacy toolkits for the broader community to use. Another thing we did with sharing people's stories which was recommended by some of the folks in our community council who spend a lot of time on social media, was to make sure and really be there for each other. We had a way of knowing when everybody was going to post their stories, so that we could go on to be the first persons to sort of support them, because part of what we are at NPAC is a community. We don't want anyone to feel like they're alone, so that was part of what we were doing. Next slide, please. I promise I'm almost done, so we can have questions. I see there are a lot of comments in the chat. So I just want to underscore again that though we focus on policy and systems level change, it is really our view that this requires a combination of education and advocacy, because we're dealing with something that's so poorly understood. And that our website, for example, is a real combo of this. It has a lot of information about treatment modalities and things that people, journalists, people with pain would find interesting and useful, members of the general public, and also a lot about our advocacy and what we're doing. Again, we believe that stories will help elevate the conversation from sort of the ground up, and that that's the way to do this. We tend to use stories in every policy meeting we have and every op-ed we write. Stories really shift the conversation, as we know, with these dominant narratives that have emerged. So they're really very, very important. And we're hopeful with a positive agenda to help transform pain across the spectrum, in healthcare certainly, but as I mentioned, in the workplace and beyond. Next slide, please. And in addition to our education and advocacy work, we hope for NPAC to become sort of a one-stop source for pain expertise, for why pain matters, because a lot of people don't really understand, that there are 50 million Americans, for example, living in pain every day, or nearly 20 million with high impact pain. The costs are extraordinary in the United States, at least adjusted for inflation, up to $700 billion dollars a year is spent on either pain treatment or lost work, and the consequences are dire. Being unable to participate in life is a pretty significant health issue. We want people to understand that pain is stigmatized and misunderstood. I think in many ways we're fighting a battle that's similar to the battle that people with mental health issues or depression have fought for many years, because like pain, depression is often invisible. It comes down to subjective reporting, and sadness is part of the continuum of the human experience, just as pain is part of the continuum of the human experience. Pain in a normal sense is adaptive and functional. Sadness can be an important part of our emotional development, but there's a difference between the ordinary experience of sadness or pain and the disease process of depression or severe pain processes, or severe pain, whether you consider it disease or diseases underlying it. We want to educate why health equity, arises in a unique way with respect to pain, and why it's really important. We want to activate, again, stories and real life experiences to raise awareness and translate good evidence, best evidence, newly emerging evidence and practices, as well as experience, into effective policy. Next slide. That's it, finally. Felt like I droned on for quite a long time. So happy to, I haven't really been able to follow the chat and do this at the same time. So.
All right. Well, thank you, Kate, for this powerful talk and for sharing the vitally important work that the NPAC is doing, including the planning of a deeper dive into health equity, as this is something that's really important to us at Pain BC as well. So we are running a little short on time, but because we started late, we're happy to stay on for an extra 5 minutes if that works for other participants as well, and take a couple of questions. I did see one come up I can read out. So a question from Lori, who said, do you see this turning around anytime soon? The harms that have been so significant, is it irreparable, or is there hope? So yeah, there is always hope, but do you think there is an ETA before things get quote unquote better? What are your thoughts on that?
I think it's really hard. I think that we've seen positive, it's sort of like healing. I had several ups and downs, and, ended up having to have surgeries when I thought I was all better, and finally came out doing, much better. That's kind of what's happening, I think, in the current environment. We see hopeful things happen, like, the CDC, coming out and saying its policies were misapplied, and the FDA coming out against forced tapering. And that's helped us stop bad policies like the one I mentioned that would have federally misapplied the CDC guideline across the country. It's much harder, though, to stop, to reverse policies that are already there. And I don't feel like the gains that we have gotten have trickled down to the lives of people anywhere near fast enough. And very effectively. So I do think things can change. I mean, we just had one of the things that affects this conversation. I felt like we were making a lot of headway in 2019, and then the pandemic came. And even though I've done several talks on COVID and pain, that diverted attention a bit away from the seriousness of what's happening to people in the overdose crisis. And then we ended up with a lot of multi-district litigation in the United States, which has really sort of shifted the narrative again. Although just yesterday we saw one judge in California who's basically rejected the claims of the plaintiffs entirely. So it is a dance, unfortunately. And one of the problems is that policies move very slowly. But I do see a growing recognition of the harm to people with pain. I absolutely do. It's just not happening fast enough.
Yeah, thank you very much for sharing that. Lots of positive comments in the chat, and my colleague Shrista just posted a link for people that are interested in getting in touch or checking out your website and your work. If there's any other questions, please feel free to add them in the chat. We'll just wait for another minute or so. Someone asked when this recording will be available, and I'm happy to say that it will be posted on our website probably early next week. So watch for that.
Any other questions? I'm sorry, I went longer. It always takes.
Oh, that's okay. Not at all. We started late, and thanks again so much for your patience and flexibility. Okay, a couple questions coming up here. One is, how much pushback have you had in America?
Pushback in what sense? From
doesn't say. I'm wondering if that.
We have our critics, if that's what you mean.
And has that varied across? Has any kind of criticism varied across states and regions in your experience?
I mean, I think that different states and regions have different things happening, and in some states the fight is harder. For sure. And in terms of, critics, I mean, there are people, there is a group that really doesn't believe that opioids are ever appropriate for chronic pain in any circumstance. And, they're definitely critical of our work. They're a national group that has been out there, but, I don't think there's any way to get through this without some criticism. And maybe that means we're doing something right.
Yeah, I would argue in that point right there. All right, and I think we'll wrap it up there, just because we're at time and people might have to head off to other things. But I'm so thankful to you for sharing today, and thankful for everyone who was able to join. And we'll see you next time, everyone. Thanks again, Kate.
Thank you so much, and thank you to everyone at Pain BC. We really. You guys have been so supportive and wonderful, I have to say. It's really nice to have a colleague organization really, supporting us.
Well, this is vitally important work, and we so appreciate what you're doing and all your dedication and commitment to addressing pain inequity in the US. So thank you.
Thank you.